Good afternoon, everyone. A very warm welcome to today's webinar, Brain Fitness, Enhancing Cognitive Reserve and Cognitive Resilience. As we all know, brain health is central to healthy aging and overall well-being. In today's session, we'll explore strategies to strengthen cognitive reserve, build resilience, and promote active aging. It's my privilege to introduce our esteemed speaker for the day, Dr. Prabha Adhikari. Dr. Adhikari is the professor and head of the Department of Geriatric Medicine at Yenapur Medical College and Hospital, Mangalore. She holds an MBBS MD in General Medicine, a postgraduate diploma in clinical research, and a Bachelor of Public Health. With over 40 years of clinical experience, Dr. Adhikari is a pioneer in geriatric care and a leading consultant in geriatrics, diabetes, endocrinology, palliative care, and infectious diseases. She has established 8 centers for active aging and 7 free diabetes clinics and has been at the forefront of geriatric palliative care at Kasturba Medical College, Bangalore for over 2 decades. In addition, she runs a memory clinic and an active aging program for patients with impaired memory and has published extensively in peer reviewed journals. We are truly honored to have her with us today. Please join me in welcoming Dr. Prabha Adhikari. Welcome, Doctor.
Yeah. My, is my slide visible?
Yes, ma'am.
Yeah. So, good afternoon, everybody. Shital told me that this is a month of healthy aging, but I am telling that this is a month for Alzheimer's disease as well. So, September we create awareness on Alzheimer's disease and its clinical manifestations, and also talk about prevention of dementia. So, since I'm a geriatrician, maybe I will focus mainly on geriatric cognitive reserve and resilience. So I bring greetings from the Department of Geriatric Medicine from Yenapur Medical College. Uh, so you can see here three trees. The first one is a green one, and the middle one is a yellow one, and the last one is a red one. So when I show this tree, I compare the leaves of a tree with the neurons and the branches of the trees to the connecting fibers between the neurons. So when you talk about cognitive reserve, it is what we can achieve by the age of 5 or 6. Only up till then we have multiplication of cells in the brain. So the leaves can be really full, and we want it to be as full as possible. So that is the purpose of early education of children, and then also protecting the mother and looking after her nutrition during the brain development, and have a nice environment for the child to grow, all that. Because after that you don't have any multiplication of neurons, but the neurons can increase in size with education, with social connection, with good lifestyle and other things. So it is important that we should have a brain with full cells, not only in number but also in size, by the time we become an adult. So it's very important to build a very good cognitive reserve, because if we have many cells, and if the cells are pretty large, we can always, like, even if we lose a few cells, we can still manage. When I talk about cognitive resilience, it comes from the neuronal connections. So although we cannot increase the number of cells, or although we cannot increase the size of the cells after a particular age, we can always increase the connecting fibers and their connectivity, so that even if we lose a few cells in one part of the brain, we can still manage by connecting to other groups of cells which can take over the function to some extent. So if you take the middle age, this is how our brains will be from middle age, maybe from the age of 40 to 60. This is how our brain will be. We would have lost a big number of cells. However, our connections are still intact. So nobody can say that we have cognitive impairment. But you will have people reporting some kind of memory issues from the age of 40. Around the age of 40, they say, oh, I can't remember the name of that person. Yesterday there was a bright nice person who said, oh, I met a very familiar person, I could not get the name. Or similarly, you may miss some important dates as you are in your busy schedule. And multitasking you may still be doing. You'll be able to multitask, but when you do multitask, something may be forgotten. But look at the last tree. Here you can see that most of the cells are gone. You still have a few cells left, and a few connecting fibers are intact. So even at this stage, if you give a stimulus, definitely the person can be can have cognitive resilience to function. So that's why when we do MRI, when we see do CT scan, it will show in a particular patient, it will show so much of brain atrophy, but still nothing would have happened. Similarly, we see what we call as white matter hyperintensities, which are increase in white matter. But again, the one person may have complete cognitive impairment and physical disability of movement with a small amount of white matter accumulation. Whereas another person who has got a very good cognitive reserve and who has neuroplasticity can manage with normal cognition and normal functioning. So it's very important that we understand the concept of neuroplasticity, because cognitive reserve we should have built in a younger age, and whatever we have built, that's it. We can't further increase the cognitive reserve. But neuroplasticity we can increase at any stage and any age. So that is the basis of my talk today. So all this I have learned from my elders as I saw my father and mother go through aging. So my father was very active and independent till 80, although he retired at the age of 55. But he was never tired. He was handling lots of intellectual work, and physically also he was very fit and active. He was not only activities of daily living independent, but he was also independent in all instrumental activities of daily living, and he was also having advanced activities of daily living. That means he was contributing a lot to the educational institutions and universities, and also to the family. He also did lots for social causes. So he was the president of a home for the aged for as long as 10 years. He helped in a colleague found it. He supported a professional and business women who have retired, a club, Probus Club. He was also an active person in Association for the Blind. He also he did certain things which he wouldn't dream of doing. In the sense, he was from the science background, but he was the principal for a management college institute. That was the first ever management college that came up in Mangalore. And he was also authoring a PUC physics textbook, which was very, very useful for the PUC students to understand physics and score marks, which he was updating every year. So his brain was functioning very full. He was also walking 5 kilometers a day, eating healthy food, and he had clear purpose defined in life. To the family also, he was very, very contributory. As we were 8 sisters, probably his goal was to see all the children get educated and also get married to appropriately qualified people. So he was busy with all those things. Plus, he was enjoying grandchildren, and you can see my daughter sitting on the lap of my father. It is around this age that my father had some issues. That is after the age of 80. He was hypertensive for 20 years and very well controlled, but suddenly the blood pressure started fluctuating. He had epilepsy in midlife again, which was very well controlled. He had coronary artery disease for 10 years, but it was also well under control. But the starting trigger for his cognitive decline was a loss of vision. He lost vision in left eye as he got his left lens implanted. He had a vitreous hemorrhage. The surgery was fine. 2 days later, he felt he couldn't see anything. And when he went there, the left eye was totally blind. But he sort of agreed or decided to manage with the other eye, which was already operated and which was normal. But very slowly, even that eye, he started losing vision. And that was the time he had several issues. Slowly, his cognition came down. He started losing way. He started forgetting that he has paid income tax, and he would go again and again to pay. Although he and his strong purpose was for life was almost over. He knew he couldn't write physics book anymore. He couldn't serve in educational institutions anymore, and the family, like all of us children, were well settled by then. So this is what was happening. He was depressed, severely depressed also. He even stopped going out. Although there was some vision left in one eye, he stopped going out. He even stopped watching the TV or even newspaper. He did not want because he could not uh, see it. Although later on we learned that his one eye could be rescued by laser therapy. In that 6 months, his brain had degenerated completely. So the brain degeneration progressed further. He even forgot to walk and move independently. He forgot the face of my mother, and he used always call her some social worker or somebody like that. He had even forgotten that he had retired. Thankfully, he remembered some of us, his children, and he remembered his old friends. So that is where I decided that he needed a place to go every day where he can socially interact and also get some physical exercise. So that's where I created a center for active aging by calling some of my own father's friends who had retired to come there, and our physiotherapy department said that they will guide them in exercise, and that's how KMC Navachaitanya, an active aging center, was born. So after that, uh, of course, we knew that there's something seriously wrong. We took him to the man's for diagnosis, where he was diagnosed to have a mixed dementia, that is Alzheimer's, with a rapidly progressing vascular dementia. So this is my mother. So we decided, oh, now once we got the diagnosis of dementia, we started understanding his behavior, and we started taking him to the center every day. And my sisters also said that they will support my mother by taking turns to be with my mother and father. Like by they put a timetable so that although I was with my parents, they didn't want me to be burdened. So they agreed to come and support the family. So we had lot of good things after that. We had several family get-togethers. We made several trips wherever my father worked earlier. Trip to Markara, trip to some other places. He wanted to go to, my mother wanted to go to Goa where my cousin was living, so we went there. We also went to my youngest sister's in-laws place, which my father couldn't go because he was having some, he was pretty down at the time of the marriage. So even we made all those trips together. So the intervention that we did, the active aging center intervention, along with the medications for memory enhancement, which we got from Nimans, because my father was the first one to use rivastigmine at that time, things became much better. Later on, he did have a fall and a head injury, because of which his mobility was restricted, and also his ability to speak. But the dementia did not progress, and he started recognizing my mother, and he would always give a sweet smile before we took my father to the active aging center. So this was the daycare center that we founded in 2002. And today in 2025, my father is no more, and several of these friends are no more, but the center is still existing, and it is really enrolling all the retired people into active aging. So the question came to all our mind when my father got Alzheimer's and a vascular dementia. The question all of us had was, why did he have to get it? Because he was so active. He was practicing all the principles of active aging, but still he got it because it was the biggest risk factor was age, because at age 80 you have 1 in 4 or 5 chances of having dementia. He had several childhood risk factors like low birth weight. He had a lot of psychosocial stress in childhood because he lost his father as soon as he was born, and his mother lost her vision during a cataract surgery uh, when he was a baby. So you can imagine the stress that he could have had, and probably the nutrition of mother was also compromised. And at late life he had vision loss, and about 6 months the socialization could not happen. He was depressed, he could not do physical activity for 6 months, and he had also developed sleep issues with what we call as uh, REM, sleep disorder. He would suddenly scream at midnight, he would see bad dreams, and he would be fighting people. All that used to happen. So all these risk factors attacked him together in the 6 months that he was physically and mentally inactive. So, what protected him from dementia up to the age of 80? It was his physical activity. Diet, he was a very strict for diet. He had no diabetes. He was socializing. He had a very strong purpose for life. He was reading, writing, even a book. He was taking his BP medications regularly, dyslipidemia treatment he was on aspirin, he had very good hearing. He lived in a house with very good environment where there was no air pollution. He had no head injury until then, but after head injury, he declined. He was not a smoker, not an alcoholic. So up to the age of 80, he was very, very healthy. His brain was healthy, he was healthy. So today we know that although we cannot change the unmodifiable risk factors, like uh, we can change the modifiable risk factors at any stage of our life, and that can reduce the burden of dementia by 47.5% if we address just these 14 risk factors. So what are those 14 risk factors? I told some: physical inactivity, smoking, excessive alcohol, air pollution, head injury, infrequent social contact, less education, obesity, hypertension, diabetes, depression, hearing impairment, high LDL cholesterol, and vision loss. To this, I also add some more risk factors, that is no brain stimulation activity, no purpose in life, eating unhealthy food, and of course, education was already there, and sleep, poor sleep. These are another four modifiable risk factors that we can add. Non-modifiable risk factors, I've already told, age is the biggest risk factor for Alzheimer's disease. At 90, you may escape up to 90, but once you're 90, again, there's 1 in 3 chance of you are having Alzheimer's disease. Female gender is more vulnerable because female brain is supposed to be smaller in size. If somebody has family history like me, I am at a higher risk than other people. So if I've had a low birth weight uh, in childhood, that means I will get diabetes, hypertension, heart disease, or a stroke at a very early age, and that will increase my risk of getting not only Alzheimer's disease but also stroke. So I can have a combination of Alzheimer's disease and vascular cognitive impairment. And if there is any childhood psychosocial stresses, again, that can contribute. A parental conflict or abuse, child abuse, etc., can increase the risk. So there are brain diseases that will hit the aging brain, which can again make us lose many of the brains in certain places or diffusely. So Parkinson's, strokes, deficiencies like B12 and folate, normal pressure hydrocephalus, where the ventricles enlarge and compress the neurons around the ventricles. Autoimmune brain disease, uh, especially if it is diagnosed very late, the brain cells would have completely died and degenerated because of neuroinflammation. Head injury, again, cranial head injuries, intracerebral injuries will damage lots of cells, although you may somehow manage and get up. So brain hemorrhage also, same thing happens. Subdural hematomas, again, if it is not treated early, it can really compress the neurons and predispose them for dementia. Hypothyroidism, especially if it is not treated early, it can lead to cognitive impairment. Hyponatremia, recurrent hypoglycemia itself can damage the brain. So the brain diseases, either because of nutritional or endocrine factors or metabolic factors or structural disease, can damage the brain. But many of these are reversible. Coronary artery disease, we are very happy that our elders are living longer because of the stenting and CABG. But when we put a stent, the blood supply nicely increases to the heart. But from where can it be stolen? It can be stolen from the brain. So because heart becomes the preferred organ because of the stent, and it can be stolen. Kidney, it may not steal because kidney failure may occur. So again, after CABG, you put such huge bypass grafts, and the blood can be diverted from the brain to the heart. So this can also lead to cognitive impairment. It is more so with CABG patients, but however, if you have a very good brain reserve or cognitive reserve, this may not affect the person at all. But if somebody has a borderline reserve, and then if the person doesn't follow active aging principles, that is exercise, diet, good habits, socialization and all that, then such a patient may develop cognitive after CAD, stenting or CABG. So I've already told that cognitive reserve comes from having many brain cells, as many brain cells as possible in childhood, and also during neuronal development when the child is in utero, and later on with education and knowledge, the cells engorge. But cognitive resilience can be built at any time, as I told you. So this is very, very important to know that number of people with cognitive impairment and dementia is rising like anything. You can see the figure from 2019, 55 million dementia patients. By 2050, it is almost tripling with 130 million. And it is such a costly disease because you have multiple people to give care. If the initial stages, it may be one caregiver, but as the disease advances, you will require 2 to 3 caregivers. And if you have no family members, you'll have to hire at least 2 caregivers, and that costs. Plus, these patients may fall, they may have several other issues like head injury and other comorbidities, which can also cost a lot of money. So US dollar 2.8 trillion is the expected cost of caring for dementia in US by 2030. So we are very close to 2030. How from 1.3 trillion it has more than doubled. Or is India lagging behind? Definitely not. We are following US in developing dementia. Just if you look at the number of people with dementia as estimated by LACIDAT study, 8.8 millions in India suffer from dementia, but 90% do not even receive the diagnosis or the treatment or therapy. So this is the prevalence. It is likely to rise exponentially, especially in countries like developing countries. It's going to rise more. You can see the pink colored developing countries where the rise is from 29 million to 107 million, whereas the developed countries are becoming more steady from 20 to 44, only doubling, that's all. So we are the ones who will suffer more. So one is we don't have awareness, but we are diabetic capital and hypertension capital for the world. So naturally, when the risk factors increase, the number of patients with dementia will increase. And when cardiac healthcare improves, we will survive longer and longer. And that's how we can be hit, anybody can be hit with dementia. So, what is dementia? What is dementia? We loosely use this term. It can be described as a group of disorders, brain disorders, that affect memory, thinking, behavior, language, and emotion. Alzheimer's disease is a type of dementia, but there can be other dementias. In India, vascular dementia is very common. Lewy body dementia, frontotemporal dementia are less common, I would say. So, if you want to call somebody with memory loss as dementia, so the definition says it is a progressive loss of memory or another cognitive ability, because all people don't start with loss of memory. Only Alzheimer's starts with loss of recent memory, whereas other dementias start with maybe language difficulty or hallucinations, or they may have stroke and mobility issues as the starting point for the patient. This progressive loss in memory or a cognitive ability should be present for at least 6 months, because if it's shorter than that, it is something else. Either it is a vascular um, event, or it could be delirium, or it could be depression, or it could be even an autoimmune brain disorder. This should interfere with living. Patient should not be able to uh, live independently with the onset of dementia. And it can affect not only memory but other cognitive functions. So it should be, um, of course, it can be memory alone, but usually something like executive function will also be lost. It should not be explained by dementia or delirium. So, as I said, Alzheimer's is a type of dementia where its pathology is very, very clear. So, we have double attack in Alzheimer's disease. One is amyloid plaques. Amyloid is a protein. All of us have amyloid in our brain, but it gets cleared by the good circulation that we have. In patients with Alzheimer's disease, amyloid accumulates and accumulates in the brain. It can occupy 80% of the brain, 90% of the brain, depending upon the stage. So these amyloid plaques are outside the neurons and they compress the neurons as well as the neuronal connections. But inside the neurons, you have a protein which gets precipitated, which is tau protein, and that will kill the neuronal cells. So tau protein forms a neurofibrillary tangle like a needle it is, and it will kill the cell. So this can be confirmed by either PET or functional MRI studies or brain biopsy or CSF, tau protein, or even now we even have a blood biomarker for the diagnosis of Alzheimer's disease. We should never forget the reversible causes of brain problem. As I told, vitamin deficiencies, thyroid, metabolic conditions, subdural hematoma, NPH, autoimmune brain disorders, delirium, depression, alcohol induced brain disease, all that we have to rule out because many of them are treatable. So once the brain cells start declining, suppose say one area does not have the brain cells. For example, it is hippocampus, which is required for registering a recent things. So like for me to remember that today I have a webinar, okay, I have to have a good hippocampus. Otherwise, I will depend on my secretary or some family member to remind me. If my hippocampus is not good, somebody else has to remind me. So, memory loss, that can be that. Suppose I make mistakes in remembering a recent event or remembering something like which has to happen tomorrow. Somebody has told me tomorrow there is a function, please come. Okay, I would have agreed, yes, I will come, but then I totally forget about it, and when they call also I tell no, I have not agreed for anything, I am not coming. That is memory loss. Okay, difficulty performing very familiar tasks. Okay, now if you ask me to write, so I can, without thinking I can write, whereas somebody with a dementia will have to break it up into multiple components. I have to take the book out, I have to take the pen out, okay, I have to remove the pen cap, then I have to open the book and then write. So it simple writing will be 5 tasks for me, and I may forget one of the tasks. Then I may not be able to write it out. I may forget to open the book. I may forget to open the cap of the pen, and I may be writing like that. So something which is familiar, they are struggling to do. That means there is something wrong. Problems with language. Okay. Oh, many of us forget a word. Like even I'm struggling for a word right now, but that is a part of normal aging because after some time I'm able to get that and I'm able to continue my presentation or talk or whatever it is. But a person with dementia will have lot of difficulty in understanding the language as well as in the spoken ability to speak a language. Disorientation to time and place. So they will lose their way in familiar surroundings. Uh, Mostly because, say, suppose they have changed the house. Like, say, now I have changed the house and moved to an apartment. Okay, but if I have dementia, I only remember the old house. Okay, when I come out of the new house, I will expect the same scenarios that were present near my old house. So when I don't find it, I completely lose the orientation. Okay, so that's what happens. Poor or decreased judgment. So generally, as elders give us an opinion or judgment, or like if you can ask, Papa, can I go to Bangalore tomorrow because I have a function, but the children will be with you. Is it okay? So he, if he is normal, definitely my father would say yes, absolutely no problem. It's a pleasure to look after the children. You go, okay, but such a judgment a person with dementia cannot give. Problems keeping track of things, especially when there are many things, it may be difficult even for us, but we may have a method to keep track of things. Misplacing things. Okay. See, I have my spectacle. I misplace it. So I keep many spectacles all over. In my clinic, a spectacle, in at home, a separate spectacle, in the hospital, a separate spectacle. Okay, but if I may lose, but if I think where I used the spectacle last, I can retrieve it. Okay, whereas if I keep the spectacle in an inappropriate place like a refrigerator, that is abnormal. Changes in mood and behavior. Okay, somebody who is very jolly becomes very sad suddenly, or somebody who was not talking to people suddenly becomes social and talk to lots of people. So that itself can be a warning sign. Challenges in understanding the visuospatial information. So driving, okay, like somebody was driving so nicely, suddenly finds it very difficult to maneuver the vehicle, okay, or understanding anything in the environment. Withdrawal from social or routine social activities. Again, suddenly you don't want to go anywhere, you don't want to mix with your friends, okay, that itself can be a warning sign. So, although it starts with warning signs, which is often missed, when they start having troubling behavior, which is seen in the moderate stage, patients are always brought to the doctor. But what we want for brain resilience is the first stage, when they only have one or two warning signs. At that stage, we can cash on the resilience and stimulate the brain from all ends so that the connecting fibers connect to whatever neurons are left. So look at the troubling behavior in the moderate stage. They can wander and go and get lost. Okay. There was a pediatrician who was sharing the information with us that his mother was found around 36 miles away and dogs had bitten her and she was bleeding, and that's how he found her. And after that he had to send her to a care home because at home the caregiver was not able to restrain her from going out. So incontinence and insomnia could be very very troublesome for the relatives. Repeated questioning, okay, today I'm supposed to be in a webinar but I keep on asking, when is the webinar, when is the webinar? If I keep on asking Sheetal for about 10 days, when is the webinar, that is a an irritating sign. Accusing people of theft because these patients misplace things and then they can't find it and they think there must be some theft, okay. And loss of language, as I told, hallucinations and delusions are very very troubling. Searching for the lost things, the whole day the person could be searching for the lost things, or somebody could be singing the same song, same tune for ages, refusing to eat or bathe, dragging furniture and rearranging. All these are troubling behaviors. They can be very angry suddenly and aggressive, or they can be very much agitated and restless. So all this bring the patient to the hospital. This is what I was telling. Aggression and agitation are very common in moderate stage of dementia. In late stage, they are not having any speech. They can't take feeds. They can have pressure ulcers, and they can be bedridden. Usually, this is the stage of complete neuronal loss. But however, what we see is their resilience is still there. That means the connecting fibers are still there and they do connect sometimes to some neurons and they suddenly show some emotions or suddenly utter a few words. So, how do we build our cognitive resilience? As I said, cognitive reserve, we have lost that age where we are supposed to have built lot of cognitive reserve. That means brain cells we can't now increase in size or we can't really increase them in number, but we can definitely increase the connections. So, a finger study, a Finnish geriatric study showed that there are 5 things we have to do to improve cognitive resilience, and they have shown it even with people with dementia improving, early dementia, early cognitive impairment, almost improving to a great extent, as much as a new drug that has come, lecanemab, which costs huge lakhs of rupees to produce very little effect. So what were the 5 fingers that they used? Okay, the one intervention was exercise. Second one was diet called mind. Third one was group activity and social connections. Fourth action was control of diabetes, hypertension, cholesterol, and weight, and cognitive stimulation activities twice a week. So these 5 simple things which all of us can do to improve our brain resilience. So you can see there the same thing, 5 fingers. So protect your heart, check your heart, check your risk factors for heart problem. That is obesity, hypertension, cholesterol, diabetes, etc. So let us see. So this was the result. So the neuropsychiatric battery improved by 25% in through this multi-domain intervention. So it not only prevented brain decline, it improved brain, but it also improved function. That means normally age will have functional decline, but this group did not have much of functional decline. New chronic diseases were also prevented. So it's really a good intervention that I would recommend for cognitive resilience. So exercise. How much should a senior exercise? 30 minutes of aerobic activity almost every day. At least it should be 150 minutes per week. It should be of moderate intensity. You don't have to do the real fast walk or high level aerobic activity. Strength training twice a week. Balance training 3 days a week. Flexibility exercises 3 days a week. Where will the elders go to get all of it? They can walk, that they will do. But how do they know how to do strength training? Gym is not the answer for our elderly because they will break uh, muscles there, especially the frail ones. So they can do low intensity strength training exercises. Coming to diet. So as I said, the diet was called as mind diet. It was a mixture of DASH diet and Mediterranean diet. So what is DASH diet? DASH diet is a dietary approaches to stop hypertension. So it's a diet which can stop hypertension. So how much of what they should eat? 5 servings of whole grain carbs. That means each serving is around 25 grams. Okay? So instead of eating rice all the time, it's better to have whole grains like millets and ragi and jowar in the diet. At least some serving. 8 servings of fruits and vegetables. This is something which is not done by our elders. They will eat very little vegetable and they fruit maybe one fruit serving they'll take. So they have to have 8 servings of fruits and vegetables. 5 servings of protein, which include 2 milk servings. Again, milk they reject, saying that it will cause sputum, kapha, and all that. Healthy oils, herbs which are brain healthy. In Finnish study, they used whatever was available there, but we can use something like tulsi, brahmi, ashwagandha, our pudina, those healthy herbs we can use in our diet. Avoid sweets, sugar, jaggery, deep fried and high fat food. Eat diet rich in omega-3 fatty acids, which are rich in fish, nuts, especially walnut and almonds. Not sure about groundnuts. Choline containing food we can eat. Acetylcholine improves uh, cognition. Eggs contain choline, so eggs can be given every day or at least 3 days a week. Serotonergic food like milk and banana both contain serotonin. So again, it will prevent depression and improve brain health. Curcumin and kesari, they are a very good food for resilience. That means the connecting fibers increase. Neuroplasticity improves with that. Exactly how much to take and all is not known, but we can take small quantities of curcumin, probably amounting to about 5 grams. Along with pepper, if you take, its bioavailability is better. Oil, which oil to use? They have used olive oil, but we can as well use our coconut oil and groundnut oil instead of olive oil. Salt to be restricted to 5 grams a day. So this was the mind diet which we can easily follow in India as well. So coming to, as I said, comorbidity optimization, glycemic control has to be optimum. It should never go slow, too low or too high. We have patients as they grow older, the glycemic variability increases. So 400 one time and fasting will be 60. So hypoglycemia damages and hyperglycemia also damages. They can produce brain damage, and we have patients coming in with chorea, athetosis, tardive dyskinesia just because of this drama of hyper and hypoglycemia. Hypertension control has to be optimum, like 130 to 80 is the optimum blood pressure for brain, and the diastolic should not fall below 70 as we do that. Again, the blood pressure variability is very high in this population, and that can lead to cognitive decline. So we have to make it first steady and then bring it down slowly. Orthostatic hypotension again can worsen cognition. We can improve it, and we have to treat comorbidities like Parkinson's and neuropathy, B12 deficiency, etc. Sleep management becomes very important. As I said, only in sleep we have kind of consolidation of our memories. So if we can't consolidate our memories, we will lose them. So first and foremost is we have to rule out obstructive sleep apnea, which is very common in this population. We have to rule out REM sleep disorder and behavior, and if diagnosed by a sleep study or by history, simple things like melatonin and iron level correction helps. So simply giving iron in people with low serum iron is helpful in improving sleep. Of course, if none of these things improve, we do use either pramipexole or clonazepam. Restless leg syndrome is again a very common sleep disorder in older people, especially. These are people who are likely to develop Parkinson's in future, and for them also, pramipexole is a drug which works very well. Depression has to be treated if it's severe with acetylopram, or if it's mild, social interventions are helpful. They can have other illnesses like heart failure, pain syndromes, which all have to be correct. Multi-component treatment again is very, very important. If somebody has cognitive impairment, something like Montessori activities, art therapy, that will all improve neuroplasticity, doll therapy, reminiscence therapy. Like you can bring back the memories by finding out up to what level they remember, and from there you can bring out the story one by one. Pet therapy, aroma therapy, even stimulating the nostrils with aroma will stimulate the frontal lobe, because through the cribriform fossa of ethmoid, you can have the aroma going and stimulating the cognition. Of course, we do have some drugs for cognition that I'm not going to talk about. We do have cholinesterase inhibitors, which are freely available now, and NMDA receptor antagonist, which is more recommended for vascular dementia or moderate Alzheimer's, which we commonly use, and it does improve behavior. And the new drug that is there now is the lecanemab, which has stood the test of time for now 1.5 years, and even UK got approval for this drug. Even in the real world setting, it was working because it is the only amyloid clearing agent that we have. So if you clear amyloid, your cognitive resilience will definitely improve. So this is the exercise group, which is coming almost daily, doing exercise, and almost around 1,500 members are enrolled into the this program from 2002. And I'm happy to say that there was only one person who developed dementia among 1,500 people. That means the intervention is working very well. When I started it for my father, I never knew that this will be the outcome of the center. But today I know that what we did was the right thing. So we started a yoga center also in KMC physiology department, and that group is also actively coming every day for yoga, and they also look really good. And we don't have anybody who developed cognitive impairment in that group. This is my mother who taught us how to keep our brain engaged and active. So, gardening is a very good hobby which really improves not only physical fitness but also it will improve cognition, reading, stitching. She was also doing crochet, knitting, cooking, talking, and also connecting people. Her memory was fantastic until she passed away at the age of 94. The cognitive stimulation activities are what we find in the internet. Everybody says doing Sudoku and crossword puzzle or all those computer based cognitive things as the cognitive stimulation activities. Maybe that is okay for somebody who's absolutely normal, but for somebody who's got cognitive decline, that is not the right thing to do. So we got a module of 14 module cognitive stimulation activities to be delivered twice a week over a period of 3 months. And it's like a school. You call all those people who have mild cognitive impairment and start with a prayer, group song, ask somebody to read news so that they are in touch with current affairs. Somebody says thought for the day. All will carry a ID card and they have to name all the participants. And each module is designed to activate one particular part of the brain which is engaged in cognition. So we ran this in Home for the Aged, and there was significant improvement in MMSE. From 18 to 24, it increased. We also ran it in our active aging trust center in the trust. Again, it went up from 21 to 24, and we ran it for another active aging group. They also it produced a lot of impact on them. They were happier, they felt better. This is the Home for the Aged inmates who who, who were very kept very active in giving a purpose for life for everybody. And also we did cognitive stimulation activities for them, and they were absolutely happy and active until probably COVID times. COVID hit them hard, and some of them did have functional decline after that. So we have run this cognitive stimulation activities even in dementia patients. We really improved cognition in these people as well, and we have run it even on an online basis where people have been happy using using different parts of the brain, because it is different parts of the brain. Nobody gets depressed. Suppose you give an activity which they can't participate in, then they'll be depressed. So if they can't do one thing, they'll be able to do another thing. There's no patient who loses all cognition in one go. So they will have some strong cognition and some which is weak. So this that way it is helpful. Dance therapy is also a way, music and dance therapy activates the brain like anything. So we have a active aging dance group. It is Bollywood dance group. In this group, there is only one junior person who is the choreographer, whereas all the rest are senior citizens, and they are all members of that group called Upasana group, where they learn Bollywood dance at least twice a week, and they perform everywhere. They are very famous and they are happy people, and their cognition has to be good because they have to sync music, the steps, and action, and they have to remember the sequence. So it's very encouraging to see the results of this. We have also started music therapy for people with less memory or mobility issues, which we are running once a week. Again, that has shown very good results. We had enrolled people with mobility issues or memory issues, and their mobility has improved, memory also has improved. Again, music stimulates all parts of brain, like each component of music stimulates different parts of the brain and makes it active. So whether it is rhythm, whether it's what we call as raga therapy, or whether it is reminiscence therapy, you make them remember a song based on the picture that you show. So many things happen with music alone. So we should use them. Yoga again is a great intervention for healthy brain. It can improve postures, it can improve breathing, because the sleep disorder breathing may disappear with yoga. There is something called as Kirtana Kriya, which has been researched by Western people who have shown that it is helping in cognition. In this, we utter only 4 letters of the music, sa, ta, na, ma, okay, with movement of the finger, and it is just runs for 10 minutes, and it has cognitive benefits. Similarly, the mudras, or uh, what I can say, gestures, they can also improve cognition. And there's one like this where you touch each finger with the other finger of the other hand, and then do this. This is supposed to be a brain mudra. Similarly, meditation can really be relaxing. Brahmari is the breathing that is recommended for sleep, before sleep. So these are the inmates of the home for the aged. They participated in skits, they were dancers, they won prizes for dance. They were very, very active, but after COVID, their activity has come down. So this is a center, like in which I started as a fourth center, where elders come and exercise together and also socialize. So environmental modification, like having fresh air, unpolluted air itself is good. Like the recent study has come where somebody who did research on environment went and stayed near the forest and ate all natural food and exposed to sunlight, and he had proven that all parameters of aging had come down in him, so which includes brain aging as well. Vitamin D, B12, and folate supplementation may be very important. Vitamin D is important to decrease the neuroinflammation, and B12, folate, all of you know about it. So this is a patient whom we lost just a few months back. She was a real heroine and example of active aging. She had dementia, but she had not forgotten her music. She could play her instruments like violin, mouth organ, as well as she could do crossword puzzles, and she could sing songs. And only last few months she became very frail, but she lived for 10 years, and the family looked after her very well, and she was very well socially connected. So once again, I show the first tree, that is improving cognitive reserve in childhood and adulthood, adolescence, and then working on neuroplasticity from adulthood to old age. Thank you.
Thank you so much, ma'am, for that wonderful presentation. We have a few questions from the audience, so let's go through them one by one. So, my first question to you is, how can physicians watching here can best advise and counsel their patients and families about maintaining brain fitness?
Yeah, because all these patients will go to physicians, because those with diabetes, hypertension, dyslipidemia, heart disease, strokes, everything, they'll see a specialist, but they are with them all the time. and they will not know that they are at high risk of cognitive decline. Diabetic patients themselves are at high risk, and hypertensives as well. So it's very important they counsel on, of course, for heart health, they will counsel on exercise and diet, but nobody counsels them on socialization. Like, they will say, oh, you are having work stress, it's better that you resign your job and sit at home. That is a wrong advice. Okay, so if it is very stressful, working is stressful, they can do something else. uh, they should not sit at home after retirement. They have to be engaged in social activities, physical activities, and they have to develop new hobbies. They can engage themselves in music, dance, whatever they like, yoga, anything, something to stimulate the brain, so that they don't become a burden to the family, because brain health is so important. Because if your brain is gone, you are not a human being. Like, it's because of the brain we are calling ourselves human beings. But if we don't have the brain itself, our brain health is so bad, we will not behave like human beings, and it is so pathetic to see how the dignity is washed off you. So it's very important that physicians counsel them on that. So, as I said, exercise, diet, they will do, but cognitive stimulation, they don't tell. They don't tell about social activities. So they can continue to read every day, because of now mobile and electronic media and AI, nobody needs to think anymore now. Like, the brain need not be used at all. If they have any query, like, even they say anything they can feed, and they can say, you remind me. Okay, then the brain won't think at all. I want an information. Earlier it was Google. Now if you put your question to AI, the answer is there, right or wrong, it is there. So thinking is not there. Learning is coming down because of the media. In Google, like in WhatsApp and social media, you go on watching videos, but there's no great learning from it. So learning activities are very, very important. Learning new things. It could be a new language. It could be something. There are people who are doing masters in Sanskrit now, learning Sanskrit. Somebody is learning to read all Sanskrit scriptures that are there. So somebody is doing uh, this thing, masters in different branches through open universities. So all that they have to keep learning something or the other. It could be cooking, like a man doesn't know how to cook, but he can learn to cook. Similarly, a woman doesn't know how to handle money. Like, she doesn't know how to operate this thing, or go to the bank and get money, or keep an account of what is spent. So she can do that activity. So whatever is not done, you can develop. So it is very, very helpful, because what I say is, the main things are five, what we call as Pancha Sutra: exercise, diet, brain stimulation activities, socialization, and managing comorbidities like diabetes, hypertension. So these five things are very, very important. If you do these five things, your sleep will be good. You will have, like, you will not be depressed. So other risk factors will go away. Actually, they'll vanish. So these five things we have to do. And again, what in geriatric practice, what we say is, if somebody is fit and healthy and doing exercise regularly, we will be counting their age backwards. Okay. See, I have been doing exercise regularly for 2 years. That means I can minus 2 years from my age up to a maximum of 10. So if somebody has been exercising for 10 years, okay, even if he's 75, he will be assessed as 65. So if he has to get benefits of, say, chemotherapy or cardiac surgery, we will say, he is 75, but he is fit. He has been engaged in physical activity and cognitive activity, socialization, everything he has been doing. So he has purpose in life. He is doing something for the society. So let us go get him to his full fitness by surgery or chemotherapy or whatever it is. So that is what we do. So that also is important. If you are sitting idle with the mobile the whole day, not talking to anybody, not bothered about what is happening in the family, and you have no purpose in life because your purpose in life is over. You finished working, you retired, your children are married, you have nothing else to do. Okay, so that kind of a person probably will degenerate faster.
Thank you for answering that. My next question to you, we spoke about AI and everything. So my next question is related to that. With AI and digital tools emerging, do you see a role for technology-based cognitive training in the Indian context?
I feel the technology based training is good enough, good when you don't have persons, okay? But if you are getting trained by a group, like what I'm talking about is socialized, yeah, so socialization also happens. The connections improve, neuroplasticity improves, so cognitive resilience improves. But if you are in front of a screen and you are getting trained, of course, there are people like now Habeld yoga is a big thing, but he goes on talking. He goes on talking about so many things. So you can connect to him. Although he's coming in the TV or in your mobile, you can communicate with him and you can get almost a live experience. So it all depends on how you use the technology. But technology without a human being, I think it cannot. It cannot replace. It can't be a robo giving us a yoga session or an exercise session. It won't have the same effect.
Thank you for answering that. Moving on to the next question. So my next question to you is, when do you recommend referring a patient to a specialist memory clinic?
Yeah. So I think memory screening, all physicians are trained in doing MMSC, uh, mini mental status examination. There's an Indian version as well, which can be done as an annual checkup for all elderly. Of course, we will miss early cognitive impairment in somebody whose cognitive reserve was very good. Like in my father's case, he had 28 marks in MMSD when he had advanced dementia because those questions are very, very simple and he would call it as silly questions. Okay. So you can miss it. So you have to use that tool. Then there are other tools like AD8 tools are there, which interviews the relative and who will tell some symptoms which could warn somebody about dementia. So that is a second tool that you have to use. You'll have to rule out depression. So any of the depression scales can be used. PHQ is a very simple questionnaire that can be used. So you can almost diagnose dementia as a physician only, then refer to a specialist. Again, specialist means if you refer to a neurologist, he will confirm that it is dementia. Okay. But again, at a particular time, he cannot handle them because the behavioral issues start. And that cannot be handled by a neurologist. Maybe he will give a medication. But for that, we require some psychologists in the team. We may require occupational therapists in the team. So it has to be a multidisciplinary team caring for people with dementia. So now we have Dementia India Alliance platform, which can be accessed through DEM Clinic. If you type DEM Clinic, you will get the link and you can register there and you can access the help of anybody there. Like you want a psychiatrist, experienced neurologist, you want a cognitive behavioral therapist, you want a psychotherapist, anybody you will get. And confirmation of diagnosis can be also done by them because not many cognitive neurologists are there or cognitive experts are there. So you can access the platform because they will link you to an expert. And sitting at home, you can get your cognitive assessment. So when at least physician does at least MMSC, he will know that this is a person who had 30 score last year. It is becoming 28. So where is it? He's losing marks. Oh, it is only in memory, recent memory. That is, we ask them for a 3 object recall. And in that, he recalls only one. That could be a patient who needs to be referred. Okay, so they can refer either to a neurologist or to memory clinic or an online memory clinic as well.
Thank you so much for answering that. And thank you so much, Dr. Adhikari, for that insightful and thought provoking session on brain fitness and cognitive resilience. Your expertise and decades of experience in geriatric care has given us valuable perspective on how we as doctors can help patients maintain cognitive health and live more fulfilling lives. I would also like to thank all the participants for joining us today and contributing to this important discussion. We hope you found this session enriching and practical for your clinical practice. On behalf of the organizing team, we extend our heartfelt gratitude to Dr. Adhikari and to all of you for being a part of this webinar. Stay tuned for our upcoming programs, and until then, take care and continue to spread the message of healthy aging. Thank you, everyone. Thank you.